Okay, good evening, everyone. We welcome back again Dr. Aslanif, who has given us a lot of talks and enlightened even me as a cardiologist on echo. All my complex cases, as you know, I sent to Aslanif. He's really a maverick in echo, and he had did a stint in Mayo Clinic, did a lot of papers on echo, and so without further ado, we do this first, then we will ask question at the end. Okay, Aslanif, let's go ahead.
Let's go ahead. Okay. All right. Can you see my screen?
Yes.
Okay. So thank you, Dr. Betty, for inviting me. I'm so sorry because of the the things that happened today. I'm so sorry. So just wanted to share some cases of echocardiogram with you all. So I will start with this case. So this is a 55 years old male patient with non-ST elevation myocardial infarction. This patient actually come to see me in clinic on the 19th of March 2022. So what follows are his echocardiogram, which is done on the same day, on the 19th of March 2022. So this is the echocardiogram. So on the upper left, you can see that the whole left ventricle is hypokinetic. This is the basal and mid anteroseptal wall. So this is where your LED is supplying the vessel. This is a basal and mid infralateral wall. So this is where the RCA is supplying the vessel. As you can see here, the LV is dilated. The dimension is 5.77 centimeter in diastole. I think normally I take the upper limit of male as 5.8 centimeter, the upper limit of female as 5.2 centimeter. But remember that that upper limit is for Caucasian, for Western population. So for Asian population, even 5.77 is slightly dilated for male. The ejection fraction is down at 30%. So this is the short axis view. So the reason I show this short axis view, right, is actually I just wanted to teach you all or just explain to you all how to name the left ventricle wall when you look at the short axis view, just some things. Okay. So when you see the mitral valve here, so this is at the basal level. When you see papillary muscle here, this is at the mid segment. Okay. If you look at here, this is LV, and this is actually RV, and this is septum. So that become your septum become your marker for naming. Okay. So this is the ultrasound probe. So that's anterior. So that is posterior. So you know that this is anterior wall, and this is posterior wall or inferior wall. So the way to name it, because this is septum, so this segment here is basal anteroseptal. This segment here, this is basal, this is infero, this is septal. So this basal infroseptal. This part is lateral. So this part is basal anterolateral. This is basal infrolateral. This is basal anterior and basal inferior. So that's how you can name the whole basal part of the left ventricle using the septal as your marker. The same thing we go for the mid segment. You look at this. This is the septum. So this is a mid segment, anterior and inferior. So how to name it? Mid anterior, mid inferior, mid anteroseptal, mid infroseptal, mid anterolateral, and mid infrolateral. Okay, so that's how to name it. To name it in short axis view, and the same goes when you go to the apical segment. This is the apex of the left ventricle. This view is actually very important because number one, we wanted to see this apex rotate anti-clockwise, because remember that the left ventricle contracts three ways. It contracts like this. So this is the radial contraction, contract like this, longitudinal contraction. It also squeeze. So the apex squeeze anti-clockwise and the base go clockwise. So that's why if you look at the single cell of the myocytes, it only contracts about 20 to 25%. but the normal value of LV ejection fraction is about 50 to 55%. So the reason is because of this three-way synergistic effect of contractility of the left ventricle. Now, I just wanted to show you the segment. So this red here, this is the inferior wall supplied by the right coronary artery. And this green is the LA supplied by the left anterior descending artery. Again, you can see two-chamber view that shows hypokinetic RCA territory and also LAD territory. So when you look at this patient, one of the ways to see whether the tissue is healthy or not is by using tissue Doppler. So tissue Doppler is how fast the tissue is moving. So the septal tissue Doppler here is 5.97 centimeter per second. And the lateral tissue Doppler is 4.29 centimeter per second. So the threshold for septal should be more than 7, and for lateral should be more than 10 centimeter per second. So this shows the tissue is not healthy. If let's say the patient have preserved ejection fraction, this number actually show you that the patient have diastolic dysfunction. So you don't even need any other parameters. If the patient have normal EF, and you can see the septal E prime is less than 7 and lateral E prime is less than 10, straight away you know that the patient have diastolic dysfunction. So I put him for angiogram on the 22nd of March 2022 that shows 3 vessel disease. Stop the procedure to offer CABG, but patient declined. So decided to do angioplasty on the 24th March of 2022 to do the LED and RCA with medical treatment of left circumflex artery. So you can see that this is the angioplasty. So this is, I'm sure for Dr. Betty, this is just a simple angioplasty. So nothing complicated. But as Dr. Betty and also everyone know, actually, when we talking about angiogram and angioplasty, even though it looks simple, because you're dealing with a vessel that is near the heart, there's always potential for complication. So it's never, even though it looks simple, never was just 100% safe. So we always have to be very, very careful. So this is pre-angioplasty. You can see that severe stenosis of the proximal LAD, and post-angioplasty where we stented the LAD and the results looks okay.
Yeah.
Again, we can see this is the right coronary artery, and you can see there is tight stenosis at the proximal right coronary artery there.
Can I stop you here and ask you what is the risk factor for this gentleman? His vessel looks diffusely diseased, even though of course there are even though there are just areas of significant blockages that make it simple for us to treat. But
Yes.
his overall disease is quite bad, no?
Yeah, it's quite bad. He actually have type 2 diabetes, and he also a smoker.
I see, no wonder.
So,
okay.
So that's the issue. So discharge with the normal guideline directed medical therapy for heart failure with reduced ejection fraction. So I give him all this medication. So for patient with heart failure with reduced ejection fraction, depending on the blood pressure, my default is to try to give 3 medication if I can. So that 3 medication is usually is SGLT2 inhibitor, ARNI, and also bisoprolol. That is default to try to give 3. If cannot, I give 2, or even if really cannot, then I give 1. So what follows after I did the procedure were echo done on the 15th of October 2022, which is 7 months after the patient first presentation. So basically, I wanted to show you how we track basically in this case the improvement in patient LV function, not only after we do the procedure. I mean, the procedure is important, but I think one thing that is more important, in my personal opinion, is the guideline-directed medical therapy. So you can see here, just wanted to show you. So this is the region that is supplied by the left anterior descending artery. So you can see that the contractility and the LAD is improved here. So this is vessel in mid and prolateral wall. This is the wall that is supplied by the right coronary artery. And you can see the contractility has improved and the ejection has improved from 30, I think 50 is too high, but maybe about 45%. So from the left side and the right side to track the improvement.
I suspect that it will improve even further.
Yeah,
Because the myocardium all doesn't look like they have infarcted. That's
right.
one. Two is, I
see.
think, as you optimize your heart failure treatment and you already revascularize 2 vessels, which I think should be adequate. I think it will improve further.
Yep. So
Very
you can, okay, continue, Dr. Betty.
Yeah, it's very nice. The results are very good.
So you can see on the left side again, you can see the contractility has improved in all segments before and after. Right. We just wanted to show you the RCA and the LAD territory from the arrow that I showed at there. And this is the 2-chamber view. Again, you can see quite significant improvement from basals. Okay, let's go back. Okay. So this is basal. So basal anterior wall, basal anterior, basal inferior, basal inferior, basal anteroseptal, basal anteroseptal, basal infroseptal, basal infroseptal, basal anterolateral, basal anterolateral, basal infrolateral, and basal infrolateral. But the reason I stress this one because a lot of doctors or the new cardiology fellows sometimes find it very difficult to name the left ventricle wall, especially when they look at short axis view. So I just wanted to give a tips on how to simply naming the left ventricle wall just by using a certain marker as your baseline.
Yeah, I think you're talking about me also, because I can't remember all the segment. But I think the take-home message here is very, very important, is that when you have a left ventricular ejection impairment due to ischemic heart disease, if you have no evidence of infarct, once you revascularize, you will see improvement, especially if you are able to optimize your heart failure treatment. And Dr. Aslanif have shown you the use of the new generation of heart failure treatment, where we have moved from ACE inhibitor to ARNI. We have added SGLT2 inhibitor, and we have also put in a beta blocker, which of course has been the standard for a long time coming. But having said that, when we started training as doctors, beta blocker was actually contraindicated in heart failure. So it's now
yeah, it's amazing how things have changed.
Yes, that's right.
You know, how we can see how medical science evolve. You know, from totally contraindicated, we thought, you know, after admission for acute heart failure to now, if they say patient admitted for decompensated heart failure, you try to still keep it on board if you can, unless if you cannot. And you know, even though these pillars of heart failure treatment is well known by many doctors, but I do see patient. I think recently I see a patient who was under cardiologist follow up. Young guy, I think 51 years old, with ejection fraction of only 21%, has been followed up by that doctor for about 3 years. But didn't have. I'm so surprised when I look at the list. There is no guideline-directed medical therapy for heart failure at all. And in fact, he was told that you know, for heart failure, there's nothing can be done.
Huh?
Just yeah, exactly.
Are you for real?
I am for real. And I mean, sometimes I thought that when I give talk about heart failure, this is a boring talk already. I think I thought that everyone know about this guideline-directed medical therapy, but to my horror, even just shocked me.
Yeah, I think that especially with so many GPs on board, a lot of the medications are very readily available. You don't have to use like ARNI. You can use your ACE inhibitor that you probably have 1 or 2 choices in your clinic. You probably have 1 or 2 choices of beta blocker. And it's very simple to actually get them better symptomatically too if you use your Lasix, but Lasix of course does not change the disease progression, but it makes the patient feels a lot better.
Yep, I think that is one very important point. I think not all medication are important only because they improve mortality or improve an outcome. Because at the end of the day, if you are ill, like if you are in hospital and feeling very, very ill, you want to get rid of the ill feeling because that's really suffering. So if you are like short of breath, that Lasix is going to help a lot. So that's very important. So I just wanted to show you, not only the LV is getting better, the tissue also is getting healthier. So how do I know the tissue is getting healthier? You can see that the movement is faster. So this is septal E prime. You can see that we start with 5.97 centimeter per second, and we end up with 8.6 centimeter per second.
Oh.
So it's normalized. Okay. So the tissue now is more faster than normal. I think this tissue Doppler is very important, and a lot of people don't know how to use it, but it's actually very easy and very useful, especially if, let's say, the patient have normal ejection fraction and have heart failure with preserved ejection fraction, where this is the main thing that you follow. And in fact, you can look at E over E prime, which is the marker of the left atrial pressure, has improved from 17 to 10. So the E over E prime average, the value of more than 14 indicate left increase in left atrial pressure. For E over E prime septum, the value of more than 15, and for E over E prime lateral, the value of more than 13. So you can see that the LA pressure has also normalized. So you expect that the reason the patient have shortness of breath in any cardiac cause is because LA pressure is elevated. So once you are able to improve the LA pressure, the shortness of breath will actually improve as well. And you can see that the lateral E prime has improved a lot from 4.29 centimeter per second to 9.1 centimeter per second. And you can see that E over E lateral E prime has improved from 19.8 to 9.4. Okay. So what is the comment for this patient? I just wanted to show you this case, a case of ischemic cardiomyopathy that improved with revascularization and guideline-directed medical therapy. In my personal experience, it is much more common to have marked improvement in non-ischemic cardiomyopathy than ischemic cardiomyopathy, but you can see improvement in both. Just wanted to show you how do I address different regional wall motion abnormalities and show you the improvement of these regional wall motion abnormalities and the importance of guideline-directed medical therapy. Okay, that's case number 1. So wanted to share you case number 2 here. I got a 33-year-old male that come with loss of weight. He had history of intravenous drug user. He started having cough and loss of weight from September 2019, diagnosed with community-acquired pneumonia and left-sided pleural effusion. So transferred to IJN on November 2019. So what follows his transthoracic echocardiogram done on the 8th of November 2019. So you can see the long parasternal long axis view. Again, you can see a depressed ejection fraction, and you can see mild to moderate functional mitral regurgitation. So what is functional mitral regurgitation? So functional mitral regurgitation is very important to understand. It is when the LV is dilated or there is some regional wall motion abnormality of the left ventricle. So what happened in this situation is that as the LV dilated, the papillary muscle actually push the mitral valve leaflets upwards apically. So and it pull the mitral valve leaflet upwards. So rather than close like this, where there is a lot of palpitation space between the anterior and posterior mitral valve leaflet, it wire a little bit like this. So this is what we call tethering and tenting of that mitral valve leaflet, and this is what we cause that mitral regurgitation. If you want to classify in this MR, this is the what we call Carpentier 3B mitral regurgitation because of restricted closure of that mitral valve leaflet. Okay, so that, however, is secondary. Okay, unfortunately, if you look at the RV inflow view here, right, you can see this big mass here at the RV inflow view. So that is the RA and that is the RV. Okay, this is the inferior leaflet of the tricuspid valve, and you can see that the tricuspid closing is actually restricted by that big mass here. And you can see in the short axis view, so this is the LA, that is the RA, okay, and you can see this mass here at the junction of RA to RV. Now, whenever you see a mass on the right side, especially when the mass involves the junction of the right atrium and right ventricle, that is something very sinister. And I will tell you what does that usually signify. A mass in the left atrium is normally, if it's a mass, it's a normally left atrial myxoma. If you see a mass in the left atrium, most of the time, not always, it is left atrial myxoma, even though it is still possible for mass in the left atrium to be undifferentiated pleomorphic sarcoma or other type of sarcoma, but normally it is myxoma. But a mass in the right side of the heart is very suspicious. It still can be myxoma on the right side of the heart, but automatically when you involve the right side of the heart, you always have to think of something more sinister, especially angiosarcoma. And especially if this mass involves the junction between the right atrium and the right ventricle. Okay, so we see the mass here. I'm worried because this is in between the right atrium and right ventricle, and that's the mass inside the right ventricle there, and it also causing obstruction to the movement of the blood from the right atrium to the right ventricle. So that's the pulmonary valve, and that's the pulmonary artery, and that's the aortic valve there. In certain view, we can see that this mass appear irregular. The mass is involved the junction between the right atrium and right ventricle, so it's very suspicious of sarcoma, angiosarcoma. Angiosarcoma is one of the worst primary malignancy that you can ever have. I have never seen patient with angiosarcoma of the heart that survived, unfortunately. So you can see turbulent flow across the RA and RV, so there is obstruction. So you have some tricuspid stenosis because of the mass as well. Now, what do you see here? So this is upper left, so this LV and RV. But if you look at this apical four-chamber view, rather than one mass, you actually see two mass. You have one mass in the right atrium and one mass at the right ventricle at the junction of the right atrium and the right ventricle. So the question is, what is the etiology for both of these masses? So now we come into the realm of cardiac mass and their differential diagnosis.
Wow.
So just wanted to give you some tips, right? Okay, if let's say someone asks you, what is the most common mass that you can see inside the heart? The answer is thrombus. The thrombus is the most common mass that you see inside the heart. If someone were to ask you, what is the most common primary tumor of the heart? Most common primary tumor of the heart, so the answer is myxoma. If people were to ask you what is the most common primary malignant tumor of the heart, the answer is angiosarcoma. Okay? But if the question is what is the most common tumor of the heart, the answer is metastasis from outside. So it looks similar, but the way the question is formulated have different answer. So one more time, if some people just ask, maybe in the exam, if you do an echo exam, what is the most common abnormal mass in the heart that you see? The answer is clot. But if the question is, what is the most common primary tumor of the heart? Primary tumor of the heart, the answer is myxoma. But if it's what is the most common primary malignant tumor of the heart, it is angiosarcoma. But if the answer is what is the most common tumor, right? Not primary, but the most common tumor in the heart, the answer is metastasis, especially for cancer of the lung, cancer of the breast, and cancer of the spine. These like to go to the heart. Okay, so we have a patient now, a relatively young patient with mass in the right atrium and the right ventricle. So what is your differential diagnosis in this kind of situation? For in this kind of situation, when you see huge mass in the right side of the heart, the most important thing is to always try to rule out that this is an angiosarcoma.
Okay. anyone who wants to answer to the mass, one
Yes.
of at least?
Yep. So anyone wanted to give a guess?
Yeah,
So what do you think about
guess.
this mass and this mass?
So here, Dr. Aslanif already kind of suggested one mass is actually the angiosarcoma. But what do you think the other mass is? Anyone? I've never seen angiosarcoma before in my life.
Okay.
I know of a person, of a doctor who has angiosarcoma of the pulmonary artery. Yeah, that is also very poor prognosis. But he had surgery to be. So this angiosarcoma, where does it come out from? Does it is it because where is it coming from? Because it's not from the blood, it's not from the heart, the myocardium in itself, right?
Yeah, it is because this is a primary angiosarcoma. So angiosarcoma is basically angiosarcoma is basically it's a connective tissue malignancy. So when you say angiosarcoma, we come from the blood vessels that supply the heart, and then it become it grows and become this mass. So this actually angiosarcoma come from the wall of the heart.
Okay, so I'll give it a try. I think the two masses may not be the same etiology because they also have the different hypoechogenicity. So maybe the other one is actually a thrombus. Yeah, let's go on, see whether I'm right or wrong.
Right. So I think that is it's very interesting, the answer, and it's almost correct. In fact, I really didn't think about that because when we see two mass at the same time in the same patient, I mean, logically we think that that is the same etiology. I mean, it's the same kind of mass, but in the two different places. But you're actually right, Dr. Betty. This is actually a two different mass.
Yeah, Serena also thinks that it's a thrombus, but she says she thinks it's an infected thrombus.
Okay.
It's difficult to know whether it's infected or not. I think
that is a very good point.
Right.
You remember just by echocardiogram, you cannot tell whether a thrombus is infected or not. So you can never tell. You know what is vegetation, right? Vegetation.
Yeah, so Vijaya thinks it could be infective endocarditis.
Okay. So like I said, vegetation, when you say vegetation is by definition is an infected thrombus. Okay.
Yes.
So that's why we cannot differentiate. That's why we need some clinical information to say whether something is a thrombus is infected or not. But I agree with you. This really look like a thrombus. It's possible that this is thrombus and this is an angiosarcoma. Okay, so yes, you are correct. These are two different mass, but this is angiosarcoma, but this is not a thrombus. Okay. Okay.
And please don't call me Dr. Betty, just call me Betty.
Okay.
So weird. Okay, go on.
So you can see this is the continuous wave Doppler across the tricuspid valve, the right atrium and the right ventricle. And you can see that the mean gradient is 3.6 millimeter mercury. So you have some sort of tricuspid stenosis, but this is functional because of the mass. So the story continue. So we did a PET-CT cardiac done on the 13th of November 2019. All right. So from the CT cardiac, they say that there is a moderate FDG uptake in the right ventricular mass, suspicious for a primary cardiac tumor, primary cardiac malignancy. They said that other differential diagnosis is cardiac hemangioma. There's also pericarditis and mediastinal lymphadenopathy, and they suggest for histopathological correlation. In fact, they are absent tracer uptake in the right atrial mass. So there is no uptake when we do PET scan. If there are a lot of uptake, there is something dangerous. Okay, meaning that it's very metabolically active. So that suggests malignancy. When there is no uptake, then suggest maybe this is a benign, benign kind of mass like a thrombus. So at that time, my thinking is because I've never seen a mass that involves the RA and RV irregular that is something other than angiosarcoma. So I think that this is angiosarcoma on the RA and RV. We also did a CT coronary angiogram in 22nd of December 2019, not 2109. I think
okay.
it's a long time in the future. I hope I'm still alive. but I
I
highly
doubt.
doubt. So the right AV groove actually encased the right coronary artery. And in fact, the right AV groove, the mass actually compressed the right coronary artery. Okay. And the
Oh, I
LAD and circumflex are normal. So actually the operation was done to take out the mass on the 29th of November 2019. They are able to fully extracted the right atrial mass. However, the surgeon has difficulty in removing the RV mass. So unfortunately, the right coronary artery was injured at the time the RV mass was taken out.
But the RA mass, when they took it out, what the RA mass is the thrombus, right?
No, haven't yet. Haven't
Oh,
given
haven't got the HPE yet.
Yes, I wanted to tell you the HPE a bit in the
Okay, go on. Sorry, so excited at the end.
sense of
Okay,
the just artificial sense of suspense. Okay.
okay.
I know it's not very exciting. It's just a mess.
Okay, go
It's
on.
not like we are uncovering a murderer in a mystery.
But this is quite interesting.
Okay, so the RCA was then ligated. However, there are a piece of RV mass still left behind. So you cannot take out the mass, and there's still mass left behind. So that is something that is very not nice.
Sorry,
So
but
what?
they managed to take out some bulk of the mass?
Yes,
Okay.
RA all, but the
Yes.
RV mass not all. Some, but not all.
Yes. So, okay.
So what follows are the images of the intra-op transesophageal echocardiogram. Okay, that's the intra-op. Okay. So this is the LA, RA, LV, and RV. So this is the mass, RA and RV mass here. So that's the angiosarcoma. So we all know that already. In fact, the HPE also show that it's the sarcoma. Okay. So this is the mass in the RA, and you can see that this is the RA mass and RV mass in here together. But this is a transesophageal echocardiogram. Okay. So you can see that the RA mass can be taken out completely, right? The RV mass, I think they did a good job with the RV.
Very good job.
Yeah. But unfortunately, there are still mass here that they really cannot take out. Yeah, they find it difficult to take out the RV mass. Right. So the story continue. Patient was discharged on the 17th of December 2019. Okay. But what actually the answer is, when you get the pathology, it is RV angiosarcoma, but the RE is actually myxoma. Okay. So I think this is the first time that I see a myxoma and angiosarcoma occur on the same time at the same patient on the same chamber of the heart.
Wow.
So RA myxoma and RV angiosarcoma. Okay.
Wow.
So this is an extremely unfortunate patient that have both RA myxoma and RV angiosarcoma.
At the same time.
Same time, correct. So obviously, patient with angiosarcoma, the mainstay is actually chemotherapy. So he was referred to oncology for further management. In fact, he was last seen in IJN in 8th of July 2020. Because the story is so interesting, I was thinking of doing a write-up and publishing it.
Yes.
But unfortunately, I cannot detect the patient last status. I suspect, I hope not, but I suspect, unfortunately, that he cannot survive.
Yeah,
So that's
3 years ago.
Yeah, that's why we didn't get the follow-up of the patient.
Okay, hold on. Before you go, I just want to say it's very funny that the angiosarcoma, the borders are very smooth and nice, even on the echocardiogram. Usually, if you always read about malignant, they don't have a capsular kind of smooth borders.
You're right. So that's why I think even though good as a rule of thumb, as something to make you suspicious, but when you come to things like this, you can never just use, even though I love echo, I don't think echocardiogram alone is enough to differentiate all these different cardiac tumors. It's interesting, but ultimately you need some other modalities. I'm not very expert in cardiac MRI, but we can use cardiac MRI, because when you use cardiac MRI, you can see the lead gadolinium uptake of the mass. So that show the vascularity of the mass. So if something that is very dangerous and very malignant, like angiosarcoma, you see a lot of uptake. For those that are like myxoma, because they are not metabolically very active, you can see a little bit of uptake, but not a lot. So that's how you differentiate when you lose cardiac MRI for this kind of patient. But ultimately, obviously, the surgery and taking out tissue is also the most important part of the management of the patient.
Of course, I've seen myxoma. The other cancer that is common when you see over the right side is actually renal cell CA.
Correct.
Yeah, renal cell CA actually grows from the IVC upwards to the RA. It's quite interesting also. Okay, we go to the next case.
All right, so we have a case number 3. We have 32 years old young female in New York Heart Association class 2, have history of mitral valve repair and also ASD closure. So that's the story. So in 2008, she have multiple ASD and anomalous pulmonary venous drainage with severe pulmonary hypertension. Echo at that time in 2008 shows mitral regurgitation eccentric that is moderate due to fixed and retracted posterior mitral valve leaflet, and that AMVL looked at that time query prolapse. Later in 2008, we have closure of the ASD, mitral valve repair, tricuspid valve repair, and the partial anomalous pulmonary venous connection repair done by our surgeon, Mr. Pao. Now, that is in 2008. These are the echo done in 9th of May 2022. Okay. So this is an apical 4-chamber view. Okay. So we can see that in the apical 4-chamber view here, this is LA, LV, RA, and RV. So you can see that there is a turbulent flow across the LA to LV, suggesting some sort of mitral stenosis. And we can see the flow conversion seems to be at the base of the mitral valve leaflet rather than at the tip of the mitral valve leaflet. Okay, so this patient have mitral stenosis. I mean, the question is why this patient have mitral stenosis. Okay, the patient also have closure of the ASD. We can see that the RV size is pretty normal. So whenever we look at apical 4-chamber view, we want to assess the RV size. RV should be smaller than LV. If the RV is similar size than LV, then it's considered moderately dilated. It's the RV actually larger than LV, so that RV is severely dilated. So the RV here is somewhat dilated, not severely dilated, but maybe probably moderately dilated. Now, if you look at this Doppler across the mitral valve, you can see that the mean gradient is very high, 11 millimeter mercury. So remember that the mean gradient of 10 millimeter mercury is considered that this is a severe mitral stenosis. Now, this is the the zoom view of that mitral valve. Now, something that is interesting about this mitral stenosis, normally when we think about mitral stenosis, especially in rheumatic mitral stenosis, the stenosis origin at the leaflet tips, right?
Yes.
Where you have the diastolic doming of the anterior mitral valve leaflet and also immobile posterior mitral valve leaflet. But in this patient, on the other hand, the stenosis is actually not at the leaflet tips. Okay, the stenosis is actually at the base of that mitral valve leaflet. Here, this is the base of the mitral valve leaflet. That is the leaflet tips. So that stenosis actually comes from the ring that they used to repair that mitral valve. And you can see that the origin of that stenosis is not at the tips, but rather at the base of that mitral valve leaflet. Okay. So in this situation, I cannot use planimetry to calculate the mitral valve area because that planimetry is only valid for someone with rheumatic mitral stenosis. So the only way that I can do and calculate the mitral valve area in this situation is to get the stroke volume across the LVOT. So in order to do that, I have to measure the LVOT radius, which is 0.85 centimeter, LVOT VTI of 19.6 centimeter, and I got the MV VTI here of 94.5 centimeter. So using the equation that the stroke volume across the mitral valve is same as the stroke volume across the aortic valve, So I calculate the stroke volume across the dilated valve as pi r squared times the LVOT VTI. So I get 44.4 mils, that is stroke volume across the dilated valve, is equal to 94.5 centimeter, which is the MV VTI, times the effective orifice area across the mitral valve. So I rearrange the equation and I can get the mitral valve area here of 0.47 centimeters squared. So it's a very small mitral valve area, but not because of leaflet tips, but because of the base of the mitral valve. This is the parasternal long axis view, and this is even more clear that the leaflet tips is actually opening very, very well, as you can see here. But the stenosis actually come from the base of the mitral valve. Okay, so it's very rare situation.
Is it LA dilated?
Yes, very
here?
dilated.
Yeah.
It's really dilated left atrium. So in short axis view, okay, if those of you who like are not aware that the stenosis actually come from the base rather than the leaflet tips. So this is the leaflet tips. This is a normal way that we do planimetry. And you can see that here the area is 1.52 centimeters squared. So if you're not aware, you might be confused. Like you will ask yourself, how come the mitral valve area is 1.52 centimeters squared, but the patient is symptomatic and the mean gradient across the mitral valve is 11 millimeter mercury? It doesn't make sense. Okay, only when you realize that the obstruction is not here, the obstruction is at the base of the mitral valve, then only you know that this is not important. The important part is the base is now is a problem where the ring is. Okay. And basically, you can see this view here that is vital. Okay, look at these 3D images here. So you can see this is actually the leaflet tips there, right? That's the leaflet tips, which is big. But at there, and you see the black shadow, that is actually the true mitral valve area. That is 0.47 centimeters squared. So you can see big mitral valve opening at the tip and very small mitral valve area at the base. So that is the origin of that mitral stenosis. Just to show you the utility of the 3D, to show you where the origin of the stenosis is. So in summary, what we in TTE, what do we have here is basically MVA by planimetry of 1.52 centimeters squared at the tips. But in fact, the mitral valve area that is important is 0.47 centimeters squared at the vessel, at the smallest point of the vessel area. So in summary, the main issue is a very severe stenosis that is originate at the base, at the annulus of the mitral valve. So actually, we did surgery on the 8th of December 2022, and what follows are the intra-op transesophageal echocardiogram image. So this is the mid-esophageal 4-chamber view, and you can see this is the annulus of the mitral valve, and you can see the flow convergence here that show the mitral stenosis at or near the annulus. This is mid-esophageal long axis view, so LA, LV, iota, and that's the mitral stenosis there. And in 3D here, so this is the annulus, and you can see how small the annulus is. So the issue with this patient is that the ring that they put during the initial surgery is too small. So what the surgeon do is, he take out the previous ring, he enlarged the mitral valve annulus, and now put a mechanical bileaflet mitral valve. So you can see that bileaflet mechanical valve. So open, close, open, close, open, close. So it open and close very well. So for those of you who never see bileaflet mechanical valve in TEE, so that's how it looks like. So this is a 3D view showing that the mechanical mitral valve opening and closing very well. So just a comparison of the two. So this is before and that is after, right? So basically, the operation was done successfully and the patient went back very well. Okay, so that is the comparison of the area of opening before and also after. So you can see how big is the difference before and after. So I just wanted to tell you, sometimes when you're dealing with a congenital heart disease, especially adult congenital heart disease, you have to be very careful in analyzing the echo images. Okay, if you're wrong, you might just say that the problem is the leaflet tips with area of 1.5 centimeters squared. You might ask to do funny thing like PTMC, the patient will already got ring and then cause disaster. So just be very careful with someone that had history of surgery before. Okay, that is our case number 3. Do we still have case time for case number 4, Dr. Betty?
I think Betty, please, Betty.
Betty, yes.
I think we will do case number 4 another time, because it's
No.
already almost 9:50. And we have some questions. So I think we do case number 4 another time. I
All right, no
tell
problem.
you, if I can, I do your echo every week, lah. Because I learn so much. If I can, I invite you for every week.
In
I
fact,
know.
I just wanted to apologize because I don't know, because maybe because I just ill or what, I just totally forget. In fact,
I think
normally
you're
what I will
so well. You never forgotten one. 2 is that you, but you look younger,
normally what I will do, Betty, is like I won't, because what I will do is actually I will just go to the library and actually because I got so many cases, I usually I will try to get interesting cases and gather it,
It's
but
very
so because of today, I just ad hocly just choose one of the library that I have and present. I'm just so worried that I cannot explain because I haven't looked at it.
Oh, don't
So
worry. Because okay, can I ask you this mitral valve, right? When they put the mitral valve, when they do the repair, they also put the ring. The ring is made from what? Because it's not so echogenic anyway, not like metallic.
Yeah, it's not metallic. It's I'm not sure what it's made of, but it is not metallic because remember when you use the ring, right, like mitral valve ring, or even if you do have mechanical mitral valve, these are all MRI compatible, so you don't need to worry about MRI issue. So it's not iron, it's not metallic iron. It's a polymer, but what kind of polymer, I'm not sure. I need to check.
I see. Okay, so and chances are you can't do the valvuloplasty, right?
Oh, yeah, definitely. This is a contraindication. So those who already have a ring, is a contraindication to do a mitral valvuloplasty. In order to do mitral valvuloplasty, number one, it must be a rheumatic mitral stenosis. It cannot be a degenerative mitral stenosis. Why? Because the reason we use that balloon is actually to crack the anterolateral and posteromedial commissure that is fused in rheumatic mitral stenosis. So if you don't have rheumatic mitral stenosis, you don't have fuse of the commissure, there's nothing to crack. So you cannot use balloon.
Okay, let me just share the QR code so that everybody can hold on. So this QR code is for doctors and mainly Malaysian doctors. Okay, only Malaysian doctors. Yeah, pause, resume, share. Can you see it? Cannot, huh? I try again. So it's for Malaysian doctors. If you are an Indonesian doctor and you need CPD point, I think you can actually go to the Facebook page and do the registration for eCert, and we will send you the CPD point. So you can also do this. I'm sure you don't need CPD points, right? Aslanif?
I'm okay, I'm fine, don't worry.
Okay, so there's some questions. Okay, there is one lady who said her name is Emma Naim. Emma Naim, are you a doctor? She's hoping that we can do a course on basic echo because she has been trying find it difficult to find a course in basic echo.
Let's do one, Betty. Let's do one.
We can do one. How long will we take?
Let's plan one day where we can do basic echo, just simple to understand echocardiogram whenever you are.
Hands-on how?
Oh, the hands-on, that one is difficult.
Yeah, that's right.
One is difficult. That one we have to arrange a place with the machine. I mean, if you can arrange a place with the machine with a volunteer, then I don't mind going there. And
I find it very difficult to do physical meeting lah. Emma, we can help you do the basic echo courses online. Yeah, we can do that. But it's difficult without hands-on, very difficult. We need a workshop to do it.
Right.
It's more interesting for me to see all these interesting cases, actually. So, okay, there's another question which Ashwin you asked. Is there any role of kinase and vitamin K2 in prophylaxis against IHD?
I don't think so. I never heard about
I
this.
never heard of this before.
So I don't think so. I really strongly don't recommend, don't use this as prophylaxis against IHD. I don't think there's any evidence for this. In fact, when you look at the name of the nattokinase and vitamin K2, a bit worried. Is it dangerous? Possible? Because I never heard about these things.
I never heard of this. And Ashwin, you must remember in a lot of cases in the treatment of coronary artery disease, especially in AMI, we actually use thrombolytic, and vitamin K actually is will increase your thrombosis level.
Prothrombotic.
Yeah, it's so I don't know where you got this from. So maybe you can enlighten us for this, because if it's high risk, I would suggest high doses of statin, really treat your hypertension to the level of 120/70, good diabetic control. Okay. Okay, Siti, no, are you a nurse? You can't open the QR code if you are a nurse, yeah? The QR code are for doctors only. And for all the doctors who cannot open the QR code, send me the name, MMC, IC, and phone number and email to 012-712-3348. Okay. And then we will do it manually. Okay. Okay. So we will stop streaming now. I was Frontier Scene. Okay. Ashwin. Frontiers. Okay, let me see. Okay, I'll open it up and I'll have a read. Okay, I'll have a look later. I will stop share now, and then I will stop recording. So thank you everybody for coming